My name's Will Barbas. I am a final year med. I also did an honours year last year, and it's my joy today to speak to you about pain, disability and palliative care, which I think is a pretty interesting topic to get going with. For you guys, I hope you've been enjoying year 4C. It must be good being back on the wards and seeing patients again. It's an exciting year amongst all the study and all the stress, because it is actually some pretty interesting specialties. So I hope you've been enjoying it so far. And if you've done GP already, I hope this is a bit of revision for you. And if it's yet to come, hopefully it's a bit of a foundation for sort of the year that you're going to be having. So in terms of why particularly for this lecture, I think one of the things to really acknowledge is that these are some of the lesser well-known topics within sort of the course. Pain, we sometimes think we know it because we take paracetamol, we take NSAIDs and we think we know how to deal with it. And palliative care, well, it's typically end of life, but it's really important to touch on these things because these patients come up in both GP land and in hospital land. And when you're sitting in front of one, you're really going to wish that you knew this topic thoroughly and know how to go about it. And finally, it's going to help you pass your exams. In terms of the MCQs, there'll probably be a few on pain and palliative care, and you might even get an OSCE as well. So it's important to know these things in that sort of respect. So let's focus on pain and specifically pain relief to begin with. So pain is sort of known as being an unpleasant sensory or emotional experience associated with actual or potential tissue damage. And I think the really important thing to get across here is the fact that pain is all about the experience. It's all about what the patient themselves are actually experiencing, regardless of whether there's tissue damage occurring. So the notion that there's sort of a stimuli activating the nociceptors, so the pain receptors, is very much what we consider at the top of that chart being the nociception, sorry. And that's basically the fact that there's damage, there's something associated with pain that's then being sent off to the nervous system, and that's what our body is interpreting as pain. But the end feeling, the subjective feeling of pain that the patient actually feels is modulated by all these other factors, such as their emotions, whether they're angry, whether they're particularly anxious about the experience, their expectations. So if they expect that they have a high pain tolerance or a low pain tolerance, if the patient knows that they have a low pain tolerance, then they're probably a lot more likely to feel a higher level of pain than someone else. And also life events. So what's going on with family, work, and in other situations as well. So pain is subjective and it's about what the patient's actually feeling. In terms of assessing pain, well, we can basically think of it in terms of whether it is acute or chronic, whether it's cancerous or non-cancerous, and whether it is nociceptive or neuropathic in its origin. So beginning with acute and chronic, we use a 3-month cutoff there. So once it's been going on for more than 3 months, that's when it's become chronic pain. And if it's occurring in episodes, then it's recurrent. If you have a patient with chronic pain who's coming in with a worsening, one of the really important things to think about is whether it's actually the same type of pain that they're experiencing or whether there's a new cause that's behind it. So the idea that they could have a chronic back pain and now an acute event that's actually causing their pain to spike up, and it's not just the fact that it's less well controlled, is a really important thing to try and elicit on their history and potentially a trap in an OSCE. In terms of taking a history, make sure you take a thorough one. You know how to do that really well by this point in the course, but elicit what's actually causing this pain. What type of pain is it? Is it a nociceptive origin, so sort of an injurious stimulus that's occurring, some sort of pathology there, or is it neuropathic in terms of the nervous system? So the typical ones are the weak, the tingling, the sharp pain. Sorry, not the sharp pain. The tingling and the shooting pain and the burning pain is neuropathic. And also the intensity of the pain. So how bad really is it? There'll be what the patient describes to you out of 10, but then there'll also be what you observe from the patient. So if they're telling you they've got 10 out of 10 pain, and then they're walking around the wards, well, then perhaps there's a disparity between your 10 out of 10 and their 10 out of 10. So it's really important to consider that in terms of how they're going. And think about whether it's due to cancer or it's not due to cancer as well. In terms of management, so a really good thing to start off with is basically to begin with, educating the patient, psychological sort of factors, and then physical factors. Pharma comes up a lot in terms of pain, but it's really good to start off at a baseline with non-pharma management. So ensuring the patient understands what's actually happening here. Why have they sort of got this pain? Is it from, what's sort of the diagnosis? What are you thinking? What is sort of the investigations that we're currently doing to think about it? And what have you done so far to them? If you come to me and you tell me a really good plan of, we think you've got some appendicitis, we've given you this pain relief and it should kick in within about the next 20 minutes, I'm probably going to be a lot more comfortable than if I'm just left in the dark and don't really know what's going on. And that comes into that whole idea that there's other factors that affect pain apart from just the stimulation of the receptors, and shared expectations with the patient about how the clinical course is actually going to go and how that pain's going to go. Are you expecting complete resolution, or are you expecting it to just dull down sort of the level of pain that they have to a comfortable level? There's also the psychological aspects, relaxation therapy, distraction therapy. If they're distracted, a lot less likely to feel pain, and also physical, so the rest, ice, compression, elevation management. In terms of this is the analgesia pyramid. So you're probably really familiar with this. This was developed by the World Health Organization many years ago. It's typically used in terms of cancer pain where they do step-ups. So for example, it begins with a baseline of paracetamol plus minus a non-steroidal. If that's not working, then we step up to sort of a weak opioid. If that's not working, stepping up to a strong opioid. So really, that's a really key concept that you're probably already familiar with. And at any stage along that, we can be adding an adjuvant treatment. So basically something else that can be used to control the pain. That's more so for the neuropathic type pains. What we do, however, generally with an acute nociceptive pain is that sometimes it's the reverse of this, where it's more so a step down. We try and intersect this step ladder at the point where we think is going to be most effective to treat the patient's pain. So for example, if a patient's just coming out of theatre and they've had a midline laparotomy, they're probably not going to be too impressed if all you've got them on is just some paracetamol 4 times a day. And that's probably not going to control their pain appropriately. So at that point, they would just start on an opioid because that's what's going to be needed to control that level of pain, and we'll step down from there. So that's sort of the principle of the ladder. In terms of analgesics as an overview, we've got simple analgesics such as the paracetamol and the non-steroidal. We've got the opioids, which can either be weak or stronger. And we've got adjuvants, so sort of the other things that we tack on, such as gabapentoids, which are anticonvulsants, tricyclic antidepressants, and the SNRIs. Regarding simple analgesics, so paracetamol is basically the first line. That's the go-to that you start off with for everyone. It's well known, it's got a good safety profile. The only real concern with it is regarding the liver issues, because it's liver metabolized. So if someone has overt jaundice, that's when we'd be a bit cautious about it. The dosage is 1 gram orally every 4 to 6 hours. So that's sort of 2 tablets taken orally. And there's a maximum of 4 grams in a 24-hour period. Panadol or paracetamol is the baseline. If we don't think that's going to be adequate for controlling their pain, we can then tack on a non-steroidal anti-inflammatory as well. That's usually used for inflammatory pain. So Panadol more for the mechanical, non-steroidal added on for the inflammatory. When we actually add this on, it's not just as if you're adding another medication. It's actually got a multiplication effect. So it's synergistic, and the effect of those combined is a lot better than just adding them together. It's actually got a multiplication effect in that. And the doses vary by which drug is used, but for ibuprofen, it's 200 to 400 milligrams 3 times daily. With NSAIDs, we are a little more conscious of the side effects. So for example, if it's taken long-term, the fact that you get an upset stomach, best taken with food, and also just the renal impairment as well. So cautious in renal impairment patients. Try and use the lowest dose for the shortest time period, and typically no longer than 5 days. Now getting onto opioid analgesics, so sort of that step up the ladder. Remember, we're keeping the paracetamol and the NSAID there, so that's sort of our baseline pain control, and then we're also adding on the opioid if that's needed. In terms of acute nociceptive pain, we use immediate release opioids, and these are added on. It's preferred that we give them orally, and the modified release typically isn't used in the acute setting. It's more so for that chronic opioid usage in the palliative care setting because of the difficulty titrating, because it has a different sort of time period over which it's released once it's in the body. In terms of opioids, consider them from a weak or a strong point of view. So the weaker opioids is, say, tramadol or tapentadol. And because they're weaker, they have less of the typical side effects. So they still have the side effects, but less. So for example, it's less likely to be excessively sedated or excessively drowsy. And then there's the stronger ones, such as the morphine and oxycodone, which have the typical opioid side effects. And we'll go through those in a couple slides. In terms of other opioids you might see on a paper, other strong ones include fentanyl and buprenorphine. Ones which have really limited usage at the moment include methadone because it prolongs the QT interval, and hydromorphone, which is easily confused with morphine, and it's about 5 times the strength of morphine. And then the ones that aren't used anymore is codeine and pethidine, because it's considered that the risk actually outweighs the benefit with these ones. Are the weaker ones used more in the elderly? I'd say the weaker ones is more so used when we need sort of less of a dosage to actually be able to reach an adequate level of analgesia. In terms of what's sort of used, it really depends on what is needed to achieve an adequate level of analgesia, and that's sort of the guiding factor there. This slide here sort of talks about what the equianalgesic doses of oral opioids are. And that basically acknowledges that we have morphine as being our set standard for basically as the opioids. And then we consider everything in relative strength compared to morphine. So we said that tapentadol and tramadol are weaker. And that's why, for example, tramadol, it says divide by 5 because it's about 1/5 of the strength of morphine. So here we require 50 milligrams of tramadol to give the same effect of 10 milligrams of morphine, because that is what is required to provide an equianalgesic effect. The same amount of analgesia requires 5 times as much tramadol as to give the same effect as 10 milligrams of morphine. It's the same with the hydromorphone. So we said that that was 5 times stronger than morphine. So therefore you'd only require 1/5 of the dosage, and that's seen here with only 2 milligrams required. It can be useful to sort of know roughly what the conversion factor is in terms of the relative strengths, and just for the common ones. The reason why it can be useful for this is, for example, if there was a question that sort of gave a patient who was on multiple different opioids and they sort of said, this is what they'd normally take over a 24-hour period. Can you please sort of understand how much they sort of need of this single drug? And therefore you'd be able to sort of all standardize it to morphine and work out how much they're needing over a 24-hour period, and then sort of provide that in a single drug or in split dosing, sort of as required. In terms of opioid side effects, there's many of them, and they occur with both short and long-term usage, and the risk increases with increasing dosage, as we sort of said. Some of the important ones to note, and perhaps the most important one, is the fact that you get opioid-induced ventilatory impairment. And that's because opioids act to be a respiratory depressant, and they also act to be sedating. So when you have increasing doses, it can cause increasing respiratory depression and increasing sedation, leading to impaired ventilation. A common thing is nausea and vomiting. It happens. Urinary retention happens. Constipation happens, especially with longer term use. So when someone's put onto a long-term opioid, it's actually really important to consider putting on a prophylactic laxative as well at the same time. In terms of ongoing use of opioids, they can develop tolerance, dependence, and opioid-induced hyperalgesia. So basically require more of the opioid for the same amount of relief. They'd get dependent on it and have a withdrawal symptom when they come off. And the hyperalgesia means they're more sensitive to the same level of stimuli that they were previously. In terms of our adjunct analgesics, the things that we can add on in addition, these are typically used for the neuropathic pain, but also just pain we can't control. So there are 3 main classes that are sort of presented in the ETG, and that's the gabapentoids, which are anticonvulsants, so gabapentin and pregabalin, tricyclic antidepressants of amitriptyline and nortriptyline, and the SNRIs of duloxetine and venlafaxine. So basically, with these adjunct analgesics, we're still using our simple analgesia of paracetamol and NSAIDs as our baseline, plus or minus opioids, if there's a nociceptive component. And then we're adding these on as well. Or if it's neuropathic, we can just use these. Side effect profile necessitates that we start low and go slow, because they've each got separate side effect profiles, as you'll sort of know from psych. How do the antidepressant drugs help with the pain? I'm not sure about the particular mechanism as to why, but basically they are known to. And it's because the pain's coming not so much from a nociceptive source, as in activating a pain receptor, but more so from a neuropathic source, so a nervous system. In terms of how we understand, okay, does this patient need to continue on their analgesia or not, or when can I stop it? So if the desired effect is basically not being achieved, if they're not getting the adequate level of pain control, really try and think about, am I using the right medication? So that nociceptive versus neuropathic idea. Is this medication actually getting to its target site? So for example, for an oral drug, the patient actually has to take the medication. It's got to get down to their gut. It's got to sit there long enough to then be absorbed and be systemically distributed. If the patient is either not taking the medication or if they're vomiting it back up soon after they've taken it, well, then you really have doubts about whether it's actually getting into the body or not. And also, what else is affecting their perception of pain? As we spoke about, there's multiple factors that sort of affect the perception of pain, which is what the patient experiences. So what else can we deal with? And that's why, as much as the pharma management is really good from a biological point of view, there's a lot that needs to be addressed in sort of the non-pharma aspect as well. In terms of acute pain, so short pain that has a distinct timeline, be really clear about how it's going to be able to taper down and cease. We get rid of the strong opioids first, tapering them down, then the weaker opioids, tapering them down, and then the simple analgesia, tapering that down to nothing. In terms of what's special about palliative care pain management, well, pain relief may not be complete, especially in palliative care. And it's really about what's comfortable for the patient. So every patient will sort of have their own idea of what they're sort of willing to accept in terms of pain. And unfortunately, quite often we can't eradicate it completely, but more so it's about reducing it to a comfortable level that's acceptable to be lived with on a daily basis. One of the reasons behind this is, especially with the opioids, we're trying to balance the side effects of these. And while we could give really strong doses of opioids, well, there's the risk basically that they're going to have really strong side effects then as well. And it's about what the patient values. So for example, if they really want to actually do something this week, so they've got a special day coming up and they want to be awake for it and not feel really sedated and drowsy from their medication, well, they may actually prioritize having a little bit higher pain level that day if it means they're able to take less of those opioids and have less sedation throughout the day so they can enjoy it. So it's about what's valuable to that particular patient. They're often going to be on a lot of medications at once. So when changing that regime, it's best to just sort of change one medication or one dosage at a time if you have time to observe what the effect of that is first before making another adjustment. Otherwise, we don't really know what works. And also considering those support and non-pharma measurements as well. Having really clear communication to the patients about what we're giving them and why, and reinforcing this in writing because they've got a lot going on at that sort of stage in life. In terms of the management for pain and palliative care, so we can have simple analgesia, which is sort of that baseline, the paracetamol plus minus the NSAID. And then in terms of the opioids, we sort of do a regime which is known as background and breakthrough dosing. This basically says that we give them a long-acting opioid that acts as a background level of pain relief right throughout the day. And that basically brings their overall pain down a bit to a lower level at a consistent level right throughout the day because that drug's acting throughout the day. And then we have a short-acting opioid as breakthrough for the patients, for the times when the patient has particular spikes in their pain level, such as the patient knows that they're about to have some sort of procedure or a dressing change, or they're wanting to go for a walk or do a particular activity and they're going to experience extra pain during this. Well, then we'll give them sort of an as-needed dosage of a short-acting opioid to increase the amount of analgesia just for that period. And then once their pain has returned to a normal level, well, that opioid is probably worn off and they've gone back just down to that baseline level, that background, which is then helping them through the day at a constant level, plus minus an adjuvant, which was sort of discussed. In terms of some other considerations, if their pain is from skeletal muscle spasm, then there's some drugs for that, such as clonazepam. If it's from smooth muscle spasm, then buscopan is a good one. If the pain is due to edema surrounding a tumor, then dexamethasone to reduce the swelling, that's a corticosteroid. If the pain is due to bony mets, we can either go down the route of a bisphosphonate or even radio or chemotherapy or surgical fixation. So let's focus now particularly on palliative care. In terms of palliative care, one of the really important things to identify from the start is that it's not just for cancer patients and it's not just the days before death. I think one of the traps that we can fall into is just thinking that, okay, we sort of identified on the ward that this patient's now dying, they only have a few days to live, let's call the palliative care team. That's where palliative care begins. But in reality, and as you'll probably see throughout your GP rotation, that's not where palliative care begins. It can sort of come in a lot earlier than that, because palliative care is all about supporting and providing comfort measures when there's a non-curative illness. And it doesn't mean that sort of, death is imminent and it's right on the doorstep. It actually means we're just supporting that patient through a non-curative condition. So in terms of that, what do we sort of do? As you can see, there's sort of that a green center green bubble that really talks about those last few days where it's all about the symptom management. But you look, as we sort of space out from that, well, we're still actually doing medical treatments. and they still have weeks to months to live, and we're still doing investigations, and we're still doing chemo and radio and surgery. It's just the goals of our care are a bit different. So instead of thinking it through a curative treatment lens, we're thinking through of it as a symptom management lens. We're doing the chemo and the radio because it's reducing their symptoms. The surgery is helping their symptoms, and that's why we're doing this, and that's palliative care. In terms of issues and symptoms that arise, well, if you look through ETG, there's going to be a whole broad range that you'll see that come up. I'm particularly going to focus on these ones today, but there's a lot more online. These are what I think are probably the best ones to go with, but heaps and heaps of things come up. Particularly, there's the GI, so nausea, vomiting, constipation, bowel obstruction, and itch. There's some respiratory as well, and we'll go through these. So nausea and vomiting, know that it's common, know that it happens, know that they normally both happen together. So in the context of the palliative care patient, if they're vomiting without nausea, think more bowel obstruction or sort of an intracerebral cause. So bowel obstruction, because it's getting right down and then it's coming straight back up. They haven't really had the time to get nauseous yet, whereas usually it co-occurs. Try and elicit what the actual cause is. And on the next slide, you'll see that there's lots of different things that can actually cause it. And they sort of lead you down different routes of addressing it as well. But try and identify the cause, because if it is a reversible cause, then instead of just giving medication such as an antiemetic, we can actually treat the cause and get rid of the nausea and vomiting itself. Consider on history, basically the normal history things. What's the frequency? What's the pattern? Is it always after a meal? Is it always in association with certain things? How often are they sort of vomiting? What are they bringing up? What sort of volume? Is there any blood in there? Associations. So is it always straight after chemotherapy? Is it always right before chemotherapy? Is it always to do with a medical appointment or seeing someone in particular? Is there anxiety? And what's the oral intake? Are they still bringing things in? Are they having fluid? Are they having fiber? Do they have an oral intake, or have they stopped sort of eating and drinking at the moment? And also, nausea and vomiting, it typically comes, you get it, you vomit, you feel better, and it's gone away for a bit. And that's sort of the pattern that waxes and wanes. But regular antiemetics can actually be useful as opposed to just giving it when needed. So if we actually give it consistently over a period, that's a better way to approach it. Regarding the causes, so you can have central, intracranial, vestibular, psychological, gastrointestinal, chemo, and refractory. Regarding central, all right, so it can be due to drugs or metabolic perturbations such as a hypocalcemia, may be triggered by just the smell or the sight of food. Intracranial, you've got a mass effect, you've got raised pressure, either by a raised acid, maybe by a tumor. Vestibular, the big thing there is sort of a MET that's sort of gone intracerebrally. Psychological, so particularly anxiety causing a sympathetic nervous system response. You get your fight or flight reaction. Especially this is sort of anticipatory anxiety. So right before chemotherapy, for example. But the thing is, the patient hasn't had the chemo yet. They're still an hour away from the actual chemo center, but they're already feeling nauseous and they're already starting to vomit. So you know then that the chemotherapy itself is not the stimuli, it's actually the association with it. Gastrointestinal has a number of sort of different sub-causes, including the fact that it's either not moving very well, there's inflammation, there's an obstruction, or there's sort of erosions from NSAID use. And chemo, well, it's therefore induced by the therapy. So if it's actually after the chemo, then that sort of indicates that. Regarding gastrointestinal nausea and vomiting, so if it's because there's poor gastric emptying, we can give a prokinetic to try and empty it. So metoclopramide or demperidone. If it's due to hyperacidity, can start off with a simple antacid, such as over the counter. Then we can go to a proton pump inhibitor, such as pantoprazole, or a histamine receptor antagonist. In terms of mucosal erosion, so typically from like NSAID usage, well, we can reduce the acidity there as well with a proton pump inhibitor. And in terms of constipation, so if they've got severe constipation, then we can give metoclopramide or haloperidol. The important thing to note is that if the constipation is due to a mechanical bowel obstruction, then we can't give a prokinetic. If we have got a fixed bowel obstruction, we can't give something that's sort of going to cause the gut to press against that, because that's going to cause issues. So don't give a prokinetic if you're suspecting a mechanical bowel obstruction. It doesn't even have to be proven yet. Can pain itself cause nausea and vomiting? Probably most likely, and that might come under psychological, I think. So these are sort of the different drugs then that we can sort of go to sort of treat the different causes. So in terms of central, we might go haloperidol and metoclopramide. Intracranial is the dexamethasone because that reduces swelling as a corticosteroid. Vestibular, chlorperazine. Psychological. So we can use a prophylactic antiemetic, so an antiemetic in anticipation of the fact it's going to come on, to sort of hope that it just abates it. But we can, if anxiety is a particular factor of the psychological aspect, so for example, they're really anxious before going to chemo, we can also use a short-acting benzodiazepine, such as oxazepam or lorazepam, to sort of quell that anxiety associated with the event. So that's really acknowledging that they probably don't actually need a long-term antiemetic because their nausea and vomiting is only to do with this single event, and and it's due to anxiety from the event. So we want to quell that. Gastrointestinal, we just spoke through in chemo. Ondansetron is the really typical one that works for chemotherapy-induced nausea and vomiting. Let's move on to constipation. So once again, good history is really important. So ask about frequency. So when was the last time they went? What's the normal pattern, the efforts? Are they having a strain sit there? How long is it taking? What's it taking for them to pass anything through? If anything, and contents, are they passing anything at all? Hard stools, soft stools, what's the consistency? Constipation is usually multifactorial. One of the good things to do is really think about the pathway of food as it moves through. What are they putting in? Is it fluid? Is it fiber? What's moving through? Is it moving? So is there peristalsis? Is the gut actually moving stuff through? Once the stool sort of gets down to the rectal area, is their sensation intact? So is their body actually recognizing that, yes, there is stool in the rectum and this needs to come out and stimulating that defecatory reflex, or is it not doing that? And then output. Are they bedbound and not really able to get to a bathroom and that's why they're holding on? Do they have issues with sort of the staff that for some reason they don't want to seek help to go to the bathroom? Do they really not, have they had a really bad experience with using a pan? That's why they don't want to use it. So is there sort of a behavioral or an issue in that regard that's meaning they don't actually want to go to the bathroom? That's why they're just holding on even though everything else is working fine. Drugs can also cause the constipation, and we wanted to monitor as there's sort of, and prevent it as there's consequences for it. You can get an obstruction, you can get a delirium, avoid constipation if we can. How can we avoid it? Well, we can have a routine for when they empty their bowels, whether it's the same time each day, whether it's after each meal, optimize the fluid and fiber in their diet and address any barriers there. If they're on opioid medication for a while, then we can consider a prophylactic laxative such as doxycycline and senna. And we'll talk more about that now. In terms of classification of laxity, this is from ETG. Basically, four main classes: softeners to soften the stool, osmotic, which is going to draw fluid into the actual bowels, stimulant to get the bowel moving, and lubricant to help the stool come out. And there's sort of the different medications there. I sort of put the brand names next to them for some. In terms of actually managing constipation, so if it's an initial constipation, the first choice is the doxycycline senna, which is known as cloxone senna colloquially. So this is a stool softener with a stimulant. If this isn't working and it's a hard stool, we can increase the amount of softener. If it's a soft stool, we can increase the stimulant to try and push it out. So try and think it through in terms of what's the actual cause, what's happening, and then what can I give to sort of combat that. So i.e. hard stool, soften it. Soft stool not coming out, stimulate it. In terms of established constipations, when they've had it for a while, hard stool in the rectum, let's give a stimulant and a lubricant to get it out of there. Soft stool in the rectum, let's give a stimulant to get it out of there. Nothing in the rectum, well, let's give a stimulant as an enema to try and push it down, and then some oral laxatives. And if there's fecal impaction, so basically that constipation where it's just impacted and it's not going anywhere, then we give a suppository of glycerol as a lubricant, and potentially a digital disimpaction, which is about as fun as it sounds. Bowel obstructions. So constipation can actually lead to a bowel obstruction. In terms of this, think about the vomiting in particular. So if they are vomiting right after a meal straight away, then it's probably a higher up bowel obstruction, like small bowel or higher. Whereas if they've got feculent vomiting, it's probably lower down. If it's a lower down bowel obstruction, you're going to see the typical abdominal X-ray signs where the gas is descending the bowel, you've got multiple fluid levels there. Try and consider what's actually causing it once again. So is this obstructions caused by something outside of the bowel pressing onto it, such as a tumor obstructing or pressing down, or adhesions between the bowel? Is it within the bowel wall itself? So the bowel's not really moving, so it's peristalsis. Or is it within the lumen of the bowel, so such as a colon cancer actually growing within an obstructing flow through the bowel? For management of a bowel obstruction, so bowel obstruction can actually be a pretty serious thing, and it can occur towards end of life, but it can also be a relapsing, remitting thing, which sort of gets obstruction, gets resolved, gets obstruction, gets resolved, and sort of occurs for a period of time. So it really depends on what's causing it, what are the patient's goals of care, and how sick are they at the moment, and where are they in sort of their palliative care journey. In terms of what potential options are, chemotherapy or radiotherapy or immunotherapy, it's very much targeted at sort of a tumor itself that's sort of causing the obstruction. Surgery, once again, resecting a tumor, resecting parts of the bowel, stenting to create sort of a passage through where there's been a blockage, or a bypass to go around it altogether. And then medical. So we can use dexamethasone, the corticosteroid, to reduce the swelling. We can use an opioid for pain, though obviously not so good if it's a constipation cause, it's caused a bowel obstruction. We can use buscopan, which is anticholinergic, for colic pain. And we can use haloperidol for nausea and vomiting. Because they're obstructed, we're not going to use the metoclopramide because it's prokinetic. In terms of itch, might sound trivial. It's probably not if you have it. Basically, we want to once again think about whether there is a treatable cause or a reversible cause to it. So do they have a good skincare routine, soap-free body wash, cool clothing, cool environment, and then there's some medications that we can add on to that. So if it's from a uremic point of view, we can go with the gabapentoids, so gabapentin or pregabalin. If it's from a cholestatic point of view, we can go from the rifampicin or the sertraline. If it is not really responding to anything, or it's not specific, so we can't really do much, so when having trouble really getting on control of it, and then needing help sleeping, then we can give them a sedating antihistamine, such as a first-generation antihistamine. Fatigue's a really common symptom, but usually occurs in the context of other symptoms as well. It's also a subjective one, just like pain. In terms of differentiating fatigue from tiredness, that's important. Fatigue is going to be persistent, whereas tiredness is more so here and then gone, here and then gone. Fatigue isn't really, you're still fatigued even if you haven't done much, whereas with tiredness, you're more tired when you've done a lot of stuff. Fatigue doesn't really go away with rest, whereas so if you tell them to sleep 10 hours, it's not really going to help them feel better, whereas tiredness, you probably can relieve that with rest, and it's going to interfere with their normal functioning as well. There's multiple factors which influence fatigue, so lots of things to explore, such as the medications they're on, their emotions, their symptoms at the moment. And basically what we try and do is we try and think, all right, what are the common things that could be causing this that we can reverse? Let's see if they're there. Otherwise, it's not investigated too often. It's more so managed. In terms of management, by educating the patient, one of the really key things is setting expectations that are realistic. Most patients know this, but once you're getting towards the end of life stage, you don't have as much energy as you did when you were 20. You can't necessarily do the things that you did when you were 20. And there's can be a bit of disparity in terms of, right, well, how limited am I in terms of what I can do? And it's really about setting expectations with a patient of, right, at this stage of life, what's probably realistic for how much energy we're able to get out of the day, and what's a realistic baseline to have. Because if we're always aiming right above what is reasonable, then of course we're sort of going to be disappointed by that. But it's really important to mean that it hasn't lost hope. Just because the patient's fatigued and tired all the time and perhaps doesn't want to engage too much, it doesn't mean they're giving up or losing hope. It just means they are fatigued, and that's okay. In terms of fatigue, if they're not eating much, people can sometimes think, well, okay, they need to eat, we need to give them food. That's not necessarily going to be the cause of the actual fatigue. They can just not really feel like eating at the same time. In terms of how we sort of can combat it, well, instead of having one big day out, how about some short spaced out regular activities? Walk today, have a day off tomorrow, walk the next day, have a day off, or maybe use physical aids. So for example, I can either go for a 10-minute walk without any assistance, or I can go for a half-hour walk with a walking frame. And I might value a longer walk because I like quality time outside, or I might value the 10-minute short walk because I like my independence and I feel the frame restricts me. So it's all about what the patient actually wants. Also address the psychological factors such as emotional support and their sleep. So sleep won't cure the fatigue, but are they getting enough rest is just a good thing to be asking from their point of view. In terms of respiratory, a few respiratory things can pop up, such as shortness of breath, a cough, and hiccups. In terms of shortness of breath, well, it's subjective. Patients are can be sometimes in their mind that, okay, palliative care, I'm sort of nearing towards the end of life, so I'm becoming short of breath now. Is this sort of how the course is going to go? Am I going to end up suffocating? And that can sort of be a real fear, not just for the patient, but for their family. And that's sort of not the case. So it can be good to reassure them for that. In terms of what we do, once again, looking for a reversible cause. In terms of palliative care, one of the key principles to remember is the fact, is there a cause that we can reverse? So yes, we want to treat the symptom, but is there actually something that's driving the symptom that we can sort of reverse and address firstly? In terms of non-pharma management, having a fan, open windows, getting that air movement, that can be just as good as supplemental oxygen. It actually works wonders in this respect. Improving their posturing so they've got good air entry and cooling them down if they're a bit hot. In terms of pharma, some morphine can help if they're not already on a regular opioid, and if anxiety is a factor, then a benzodiazepine. Regarding cough, treat the cause. If it's productive, non-productive, we can give a cough suppressant or perhaps an opioid because that'll suppress a cough as well. If it is productive, let's try and help them get the stuff out. So a physio might help, or just positioning, and maybe a cough suppressant. Hiccups, as you probably know from experience, not much helps them. If there's a cause there, we can try treat it. Otherwise, you can try things such as breath hold, sips of cold water, but there's not too much that's known to particularly work. Delirium, this will also be covered in sort of the psych aspects from the psych lectures. In brief, acute change, fluctuating course in hours to days, altered consciousness and impaired attention. Those are the really key things to know about delirium. What is it? It's under-recognized in sort of a palliative care sense, and we want to address any reversible causes. Usual measures include familiar environment, reorientate them, have pictures on the wall, familiar faces around, same nursing staff, set schedule, routine, make sure they're not sort of facing any sort of visual or hearing impairments that are sort of affecting their ability to communicate, and that's sort of bringing on a disorientation. And then pharma, we can go, first line is haloperidol. In terms of hypocalcemia, so this is one of the paraneoplastic syndromes, and paraneoplastic syndrome, if you're not familiar, basically means that we've got a syndrome, so signs or symptoms that are occurring due to the cancer, but not really due to the effect of the direct effect of the tumor being there or the direct effect of any of the mets. So it's just due to the cancer in general. And some of these include hypocalcemia or DVTs because they're hypercoagulable. In terms of hypercalcemia, they've got a parathyroid-like protein that's basically then stimulating increased calcium, and they're going to come up with the typical symptoms of this. So as you know, the mnemonic, stones, bones, moans, psychiatric groans. So basically that sort of renal stones, bone pain, those nausea and vomiting, constipation, and that confusion. How do you investigate it? Do a corrected serum calcium. If that's elevated, so above 3 millimoles per litre, that's diagnostic. First line management is IV rehydration with 0.9% sodium chloride. Give them that first. If after that IV rehydration, they're still symptomatic or they still have an elevated serum calcium, then we give them bisphosphonate IV. Spinal cord compression, basically the picture is the best description of this. There is a vertebral met here, or vertebral tumor. It is now grown to the size where it's impeding upon the epidural space and it's compressing the spinal cord, and that is causing neurological symptoms. Those symptoms can be back pain, can be weakness, numbness, tingling, and bladder and bowel, either incontinence or retention. This is acute and emergent. This is an acute emergency. An urgent MRI of the full spine to see where the compression is, because there can be multiple levels of compression, so don't just localize it to one area of the spine. And we can also give them dexamethasone. So once again, to reduce the swelling, this can be given even before the diagnostic imaging has come back. The goal of the care is to reduce the compression, whether dexamethasone is enough for this, or if we need some surgical decompression or radiotherapy for this. But basically, we're looking at removing that compression. Agitation and terminal restlessness, well-known symptom. So basically can't get comfortable. Restless, can't get comfortable. Multiple things can cause this. For example, pain or urinary retention. If there's anything reversible, such as urinary retention, reverse it. So urinary catheter, analgesia for the pain. Give them reassurance and, have their family around. So they've sort of got some familiar faces, and either a benzodiazepine if they're not already on one can help, or haloperidol if they're not already on antipsychotic might be able to help as well. Terminal care, so we've talked about palliative care being much more than just the last few days. Terminal care sort of identifies this deterioration in sort of the last weeks of life where symptoms are really progressing at this stage. There's less energy, they're sleeping more, and they're not really eating as much. And then the terminal phase, and that's where they sort of click over into, all right, this patient's actively dying now. They're sort of bedbound, they're not as responsive, they're not swallowing as well, they're not really producing as much urine, their breathing patterns might change, and their skin doesn't look too green in terms of pale or cold. Have really clear communication with the patient, with the family, with other healthcare providers. In the terminal phase, the patient's actively dying. Comfort's the priority, and we know, yes, certain measures, we've sometimes got a debate between what's going to provide the patient comfort and what's going to extend life. It's all about providing comfort measures. So whatever removes the symptoms at this sort of stage of life is what we go for. And we rely on sort of an advanced care plan as to what the patient would like during this time. After a patient's death, care hasn't ended. It's still really important to facilitate support for the family and for the carers. This can be religious, time to say goodbye, or just emotional support. One of the really good ways to do this is just to acknowledge the role that they've sort of played in the patient's life and the support that they've given over the last little period. So acknowledging the fact that they've been a massive support for that patient, that they did a lot of extra things, that were always present, that they facilitated a lot and gave a lot of themselves, and that this would have been really valued by the patient, and that they made the patient's last few days a lot better because of this, and just really giving that support and acknowledgement to the actual family who have been through this. There's also the legal obligations of a death certificate, and if you need to notify the coroner. This is breaking bad news. Spikes is the model. I think you would have come across this before, so I won't go into it in too much detail. Basically, this is a mnemonic to help you think through breaking bad news station in terms of how do you deliver news, how do you set up the environment, how do you sort of go around it, and how do you sort of wrap up at the end and go from there. Basically, the whole principle with breaking bad news is that it's patient-centered. So a private, quiet room, and ask if they want anyone with them, if they want a support person with them. Establish their sort of idea of what's happened so far and why they had this investigation. Get them to invite you to explain their results. So would you like me to explain your results today? And what level of detail would they like? Some patients don't actually want all the details. They just want to know the sort of short and sharp summary. Now, a warning shot's really good about, I'm sorry, but unfortunately, it's not the news that we hoped for. So something like that, just as a warning shot to let them know about how it's about to go. Patient-centered language, chunk and check your understanding throughout. Acknowledge their emotions. Feel free to reflect the patient. The patient's probably going to be sad. You don't need to be super excited. It's actually sad news. So you can reflect that and mirror that to the patient. Read the room and summarize at the end and allow them to ask questions so we know where to go from there. In terms of the advanced care directive, so document the patient's values and instructions in advance. This is basically their wishes and their designs for treatment when they still have capacity to make those decisions. It's completed with a doctor, so the doctor can provide context. It's really important to provide context for what their medical condition is in the expected course, and also for treatment options. Some people say that, sure, I want everything, I want every last thing that you can give me, without really understanding what CPR is or what mechanical ventilation is. So it's really important to provide the context for those things to help a patient make an informed decision. The advanced care directive is put in advance early, only comes into effect when they no longer have decision-making capacity. And it includes a number of factors, including the treatment preferences and a substitute decision maker. Okay, let's wrap up now with disability. In terms of disability, so a developmental disability is basically a lifetime limitation, comes on in the developmental periods less than 18 years of age. There can be many different areas of life that it impacts. The most well-known is intellectual. Intellectual disability is a subset of developmental. Three main components. Intellectual functioning is impaired. Usually we use a cutoff of less than 70 for IQ, but that's not a hard and fast rule. They've got adaptive behavior impaired. So for example, communication is impaired, and it occurred in the developmental period. In terms of communication, it really varies along a spectrum of how well this patient communicates to understand their baseline. Always go in with inclusion and respect. It can be a trap to sort of start talking to the carer because they're the ones communicating with you clearest, but the patient is the patient. So make sure you're focusing on the patient, giving them the respect that they're the center of the room and the center of attention. Consider the patient's normal level of communication and also how they communicate. So whether they use symbols book, electronics. For example, if there was an OSCE station on this, we did have to communicate to someone what's in the room to help you sort of work your way around that. Are they going to want to use sort of a symbols chart to communicate with you? And how do they usually confirm understanding? How do you know that everything you're saying they're actually getting? So that's a really good thing to establish. What's their yes and what's their no? In terms of behavior, I was looking through the disability lecture, and one thing that they raised a few times was this idea of ABC and 3Ps in terms of questions. So behavior can be an indication as to something going on underlying that the patient really can't communicate as well. So for example, urinary retention or a UTI. For their ADLs, behavior and communication, try and explore what the baseline for this patient is, and then what the change is. Then try and explore physical symptoms, psychiatric symptoms, and personal. So is there pain or going on? Is there anxiety? Can you tell the patient's anxious? Is there a change in environment or routine? So try and look for changes as to why, so reasons as to why the behavior has changed, to try and elicit what's going on underneath. Don't just write it off as sort of being a behavioral issue without fully exploring whether there's medical things that are underlying it that you can actually treat. In terms of consent, presume they have decision-making capacity present. This needs to be formally demonstrated if they don't. So always assume they do have capacity first, then prove why they don't. Capacity can go away for some decisions and then come back later. It's individual for each decision, so they might have capacity to consent for different levels of treatment. We want to make it all about the patient, so it's best to have them make the decision. Second best is them with the support of someone. Third is someone making a decision for them. And last is a guardianship, appointed guardian. And basically there's some special considerations. If it's minor uncontroversial care, such as a blood test, that's okay as long as they're not objecting. But if it's a irreversible significant procedure, such as a pregnancy termination, then we need special authority from a guardianship tribunal. In terms of year 4 going from here, my advice to you would be to work on the principles. There is a whole lot of detail that you are going to try and cover this year. And it's going to be difficult to do that, and you're not going to remember everything. That's just simply the fact. But if you work on the principles and understand what's going on, why is it happening, what can you do for it, you're going to be in a really good place come the end of the year, and just try and cover that broad ground throughout the year to get the principles down, because that's going to help a few things stick in your mind. And it's a lot easier to learn and remember a list of 3 things than a list of 8 things. Practice and revise early but consistently throughout the year. So for example, you've already had a couple of rotations so far. The big temptation is going to be just to put them down and then perhaps not even think about them until the end of the year comes. But try and just spend a little bit of time each week sort of consistently going back to some of the key revision things to just keep that stuff in the back of your mind. Take advantage of spaced repetition. Spaced repetition relies on needing to have that time to be able to let it set in. So it's not really something that can be done when cramming, but it's done really well, for example, when you're 6 months out from your exam. So try take advantage of that small chunks consistently throughout the year. Write your own OSCEs and practice in a group. If you practice in a group of 6, suddenly you've got 6 OSCEs to do that day instead of just your own one, but also write them. Try not to just lean on past hand-me-downs, because when you write your own, you have to think through that condition really carefully, and you also have to think through the differentials really carefully as to how it actually presents. And it makes you learn it a lot better than if you were just to pull a station out of a folder. Look after yourself. You perform best when you're running at your best. You're in a marathon this year, you're the athlete, so look after yourself. Have a balance in terms of your study life, have a balance in terms of exercise and hobbies, and try and reflect each week as well on what's working for you and what isn't working so great, and then what you can optimize surrounding that, so you're continuously improving throughout the year. And enjoy the journey. I know it's stressful, I know it's anxiety producing, I know it's tiring, but it's also a lot of fun being a med student, so enjoy it and have fun. Those are the references for today's presentation, and good luck with the rest of year 4.